This is Connor Meadows going over the ROSC, the Rosc algorithm for paramedic protocol. If you are arrive on scene and find a patient that's in cardiac arrest, and you work the arrest and you're successful and you get Rosc back on the patient, your work's not done. Especially as soon as you get Rosc back, you still have to prime the pump. You're still going to be doing CPR. So the algorithm goes as follows. You get return of spontaneous circulation. You realize this and you move forward trying to optimize ventilation and oxygenation. You're going to maintain the patient's oxygen saturation above 94%. Ideally, you want to be doing this using, you're going to want to be using capnography and waveform capnography to try to maintain PET CO2 of 35 to 40 millimeters. If you don't have access to waveform capnography, just titrate the patient's oxygen to keep the patient's oxygen saturation above 94%. Obviously, there's going to be an airway in place 99% of the time. And the big thing is you don't want to hyperventilate the patient. That's not going to help the patient at all. Another big thing, the next part of the algorithm, you get Rosc back, you're continuing CPR, you're managing the patient's airway appropriately, you're going to treat for hypotension. So the way you treat for hypertension is if the patient's systolic blood pressure is less than 90 millimeters of mercury, then you're going to, with the IV or IO that's established, you're going to consider vasopressor infusion, you're going to consider treatable causes. So if you need to give the patient fluids, you can approximately give 1 to 2 liters of normal saline or lactated ringers. As far as your pressures go, you've got your dopamine that you can give 5 to 10 mics per kilogram per minute. You can also consider norepinephrine, IV infusion of 0.1 to 0.5 mics per kilo per minute. Obviously, as with the cardiac arrest, this should have continued forward through the cardiac arrest on through the Rosc, that you're going to be considering the H's and T's of the situation. But once you get Rosc back, you continue CPR, you've managed the patient's airway, and you're treating the patient's airway, and you're treating the patient's hypotension with either fluids or pressors. You're going to continue to monitor the patient's 12-lead EKG, specifically looking for a STEMI. If you suspect that you recognize that there's a STEMI, or that there's a high suspicion of AMI, then you're going to go to the coronary. You're going to try to direct, once you get to the hospital, you're going to try to direct the patient towards coronary reperfusion. If you don't suspect that, if you suspect that the patient has a STEMI, or has a high suspension of AMI, then if you don't believe that and they're following your commands, then you're just going to basically continue to treat the patient until you can get the patient to the ER staff and let the patient be transferred to the hospital's care. If you do the 12 lead and you suspect a STEMI or AMI, then you're going to, if you believe the patient has a decreased level of consciousness after resuscitation, you should consider inducing slight hypothermia. In a sense, you want to keep the patient cold. And in general, after you get a patient back with Rosc, you don't want to warm that patient up too rapidly. That's not going to help the patient. So you want to keep the patient cool, kind of treating for shock, but also without the warming therapy, or trying to keep the patient's body temperature up. You don't really want to do that. So if the patient has a ST segment elevation, a STEMI, then the patient needs to be, if the patient has myocardial infarction suspected, you need to consider precutaneous coronary intervention to open up the patient's coronary arteries. When Mario, if the patient is not considered to have myocardial infarction, you just need to transfer the patient to, you're ultimately going to be transferring the patient to the ER, but depending on a STEMI or a non-STEMI or AMI or not AMI is going to determine exactly where that patient goes next. But your patient care remains the same throughout. You're just going to be managing the patient's airway, manage the patient's blood pressure, following where that, trying to give the hospital as much information before they get their hands on the patient and do their own independent 12 lead EKG. You want to be showing them, this is what we've seen on our EKG. This is the, once you guys take over, this is probably the direction you guys are going to be needing to go to, based on STEMI and AMI. So that is the ROSC algorithm. Pretty simple, pretty important, and that's ultimately the goal of all of our cardiac arrests, is we want to get Rosc.